Thanks very much, Charlie, for that very generous introduction. I wish it were all true. Ken, I thought that was great. My glasses aren't good enough to tell me that that's a Stanford Business School alumni tie, but I like to think that that's why you got a top grade in my course on business strategy. We're very proud of our alumni. Of course, I was trying to eat while you were talking. That caused me to leave most of my dessert in the dish, and I can hardly wait to get back in my car, drive down to Stanford, and get into the gym and start pumping iron again. I think you all know now that national health expenditures are our number one fiscal problem. I mean, it used to be just a nagging expenditure thing, but now it's really huge. The health expenditures now drain the federal budget of some $1.15 trillion a year. I mean, this is getting to be huge. Unfortunately, people don't add it all up because they just look at Medicare or then they just look at Medicaid. But you really need to look at the whole picture, which includes the $260 billion a year the federal budget loses because of the tax subsidies to employer-paid health insurance, which provide a lot of perverse incentives. So, among other things, this is straining public finances at every level of government, and it crowds out education and other important things. I'm particularly concerned these days about our deficits in education because I think our society is on a very bad track there with growing numbers of young people who don't graduate from high school and are condemning themselves to really third-rate lives. At the same time, in healthcare, there are many indicators of poor quality. I'm sure you're aware of many of them. I think of the big innovation going on right now to get the doctors to wash their hands between different patients and the high problem of hospital-acquired infections. Beth McGlynn at the RAND Corporation has done studies finding many, many errors of omission in the ambulatory care sector. So why are the costs rising so fast? Well, again, I'm sure it's pretty well known that the present dominant healthcare system is not built for improving value and quality. It's filled with cost-increasing incentives, lacking in accountability and organization, and lacking incentives to cut cost and improve value. It's a remnant of the 19th century traditional model that the medical profession fought for and got, that is free choice fee for service. And it wouldn't stand up for a year even if it had to face real honest-to-goodness competition. And as Rob Chess pointed out, employer-based insurance makes most people cost unconscious. It denies them choices of more efficient delivery systems and the ability to save money by making economizing choices, such as efficient integrated delivery systems. There are other causes: rapid expansion in technology, some of which is very valuable, but practically all of which has not been properly evaluated before being put into widespread deployment. And then, as Ken so eloquently pointed out, the growing prevalence of costly chronic conditions, so many of which are behavior-related. So as Charlie mentioned, CE did a study published in 2007 that reached the following conclusions. First of all, to mitigate these problems, America must fundamentally reform consumer incentives by giving them choices of alternative financing and delivery systems and the opportunity to save money by choosing economical systems. And we must fundamentally reform provider incentives by opening the market and leveling the playing field so that efficient, accountable care systems can compete and win customers by offering superior value. Successful systems will have to align the incentives of providers with the needs and wants of consumers for high-quality, affordable care. In brief, we need a modernized, IT-enabled, quality and efficiency improving delivery system in place of what we have now for the most part. So how does that compare with what's going on in Congress today? Well, I'm feeling really depressed, but as reported in the New York Times this morning, the bills in Congress do little or nothing to make consumers cost-conscious or to widen their choices. one promising item in the Finance Committee bill is the so-called tax on Cadillac plans, which is really nothing more than undoing the harmful effects from the open-ended exclusion of employer contributions to employee health care. Because now, for an upper income person, if he chooses a more costly health plan, the tax break pays for 40% of it. So the idea, since it's a kind of political subterfuge, is we'll come around the other side and just lay a tax on that. It sounds crazy, but I think it makes a lot of sense. But it would be much more promising if that was coupled with a widening of choices so that people could act on that new incentive and have available to select a efficient healthcare delivery system. And the bills do nothing to make that happen. Senator Ron Wyden is battling to give most, if not all people, a wider range of choices to make it possible for a market to develop and work. Some of the provisions in these bills will actually increase the cost of health insurance, including the ban on exclusion of pre-existing conditions, which is a very desirable rule, yet it will increase cost for most people, and guaranteed issue coupled with incentives to get insurance now instead of waiting until you're on the way to the emergency room or waiting until you get sick that are too weak. You know, you just look at the typical person, let's say $40,000 a year household, and as I'll comment on later, family health care now is costing $20,000 or more. And so you can start paying the $20,000 or just risk the $1,000 fine, and I don't think that's going to work. In Holland, where they do have an individual mandate and 98.5% compliance, let me tell you, they are really tough. I mean, it's like you have to pay all your back dues and a fine, and so not very many people choose to game the system. So in sum, this is at best a wasted opportunity for public policy to put our delivery system on a track to greater quality and value for money. I think that the $1.15 trillion contribution to the deficit, which is growing much faster than the GDP, is really going to put us into terrible fiscal conditions. I mean, it's got me and a lot of my business school colleagues thinking, now what do I do with my retirement savings to protect that and protect them from the inevitable inflation and the high interest rates that'll grind down the growth in our economy? Well, a lot of the CED thinking, I suppose because I was involved in it along with Rob and Jerry Grossman from Massachusetts, was influenced by experience in California. The Blue Shield of California Foundation made a grant to the CED to support my working for a year on reviewing what's happening in California. And I thought that I could offer you a few main observations about that. First of all, some employers with high visibility but small in numbers, I'm thinking of Stanford University, University of California, State of California for its employees, practice what I've called managed competition, which is a little bit like the reference pricing that Ken was talking about. That is, employer pays for the low-priced plan, gives you a range of choices, and you take your pick. And lo and behold, in those three groups, 80% of the employees choose HMOs based on group practices. And they are apparently quite happy with it. So the employers in that case are saving a lot of money. I think a few years ago we figured at Stanford if we'd just bought the fee-for-service PPO, that cost us $44 million a year more, which is probably why at Stanford the university pays for Kaiser Permanente. If you want something that costs more, you pay the rest, which prompted our president once to say to me, thank God for Kaiser Permanente. And I'll tell you some of our other numbers.